Dr. Bhatt, I'm going to go back in time a little bit and ask you about the COGENT trial. I know it was stopped early, but FDA did release a black box warning for that also. Um, Going forward, how do you do that in practice with patients who need a PPI and need antiplatelet therapy also?
That's a good question, and everything in medicine is a shifting landscape. New data, of course, always come out, and that makes it a little bit challenging to be too absolute. But in that study, which was a trial of ACS and stenting patients on aspirin and clopidogrel, we examined proton pump inhibition, specifically with omeprazole. And the goal of the trial was to see if we could reduce GI events, and it did significantly reduce GI events, specifically GI bleeding, the prophylactic administration of a proton pump inhibitor. Now, at the same time that we were designing that trial, there was some controversy emerging about whether clopidogrel and PPIs interact. So we also looked for any sort of adverse interaction, namely any excess in myocardial infarction or ischemic events in general, and we didn't see that. And it turned out that was a small company funding the trial. They went bankrupt, and the trial stopped, but we still enrolled several thousand patients. So the trial had reasonably good statistical power. Certainly we were able to show efficacy in terms of reduction of GI events. And I think the highest risk in general in ACS and stenting patients for ischemic events is in the first 6 months, where we had good follow-up. After that, the follow-up was curtailed because of the demise of the company.
So do you choose one particular PPI over the other ones? There's been some question about maybe pantoprazole because it's a different CYP enzyme versus omeprazole.
So, I keep an open mind, and I'm never overly dogmatic about things. So if clopidogrel and omeprazole were the only agents on the formulary, and I had to use both because a patient indeed had indications for both, I would use both and not worry about it excessively. On the other hand, I would be prudent in life, and if there were all options available, the price is the same to the patient, I would likely use a PPI that hasn't been indicted in terms of these pharmacokinetic and pharmacodynamic interactions. And omeprazole and esomeprazole are the ones that have been most commonly indicted, but you mentioned pantoprazole, lansoprazole, dexlansoprazole. There are other ones as well that seem to have less of this ex vivo interaction. So yeah, why not use those? And on the flip side as well, if it's an ACS patient that's getting a stent, prasugrel and ticagrelor are options. If it's an ACS patient either getting a stent or not getting a stent, ticagrelor is an option. So assuming the patient's not at high bleeding risk, those are good options, and those get around the whole controversy and question of PPI interactions.
Thank you. Now, in the Stampede trial, which was also presented, it was unusual in that they ended up going for surgery at a BMI that is unusually low for a bariatric surgery. Any thoughts on that?
Sure. So the Stampede trial, just to make sure everyone listening knows, was a randomized clinical trial, single center. Actually, it was initiated back when I was at Cleveland Clinic before moving to Boston. It was a trial of two forms of bariatric surgery, classic Roux-en-Y, gastric bypass and sleeve gastrectomy versus best medical therapy for diabetic patients with a range of BMIs. So there were certainly some obese diabetics in there, but there were also some patients with a BMI between 30 and 35, for example. There were even a couple with BMI below 30. And as far as we could tell, the effects in general were as good in patients with a BMI, say, between 30 and 35 versus over 35 with respect to diabetic endpoints, that is reductions in hemoglobin A1C, reductions in the need for insulin, actually reduction in the need for antihypertensive medications, cholesterol-lowering medicines, and obviously reduction in weight. So our intent wasn't to study bariatric surgery for weight loss, it's already well known to do that, but to see what impact it might have on diabetes control, in particular if the control arm is the best medical care possible. And our endocrinologist on the job was someone of the name Dr. Sangeeta Kashyap from Cleveland Clinic, providing superb care among herself and her colleagues. So the medical care was really good, probably better than typically happens in routine clinical practice, and bariatric surgery still beat it.